Hi, everyone, and thanks for being here to have this very important discussion and this very comprehensive symposium. Um, my name is Anastasia. My pronouns are she and her, and it's going to be my pleasure to take you through the topic of gender-affirming hormone therapy in adults. So I'm going to share a couple of slides that I've prepared and just chat you through some of the basics on the theory behind hormone therapy for trans folk and the process of managing it, because that can seem quite daunting at first, especially if you haven't done this before. But really, kind of the take-home point of this discussion is that it is definitely well within your capabilities as a qualified provider to manage hormone therapy for trans folks. So I'm going to focus the discussion today less on remembering specific dosage quantities or frequencies or anything like that, and really try and center the discussion more around disarming the concept of prescribing hormone therapy and hopefully making it just a little bit less intimidating. So let's see if we are able to do that today. And I'm going to hope that you are all able to see the presentation now. I'm not going to know until after I finish recording this and watch the video if it worked out. So let's just hope for the best and let's dive into our chat today. So what I'm going to look at today is I'm going to talk you through some of the basics of what I've used the acronym here, gender-affirming hormone therapy. This will be familiar to you if you pick up the new Standards of Care 8 that recently came out. If you refer to the South African guidelines published in the SA-HIV Clinician Society Journal in October 2021, written by myself and an incredibly astounding team, of which some of the members you'll have already heard from today and some you still will. But then you'll see that we use the abbreviation HT or hormone therapy. You might also hear the terms hormone replacement therapy, conventionally a term that's been used for postmenopausal cisgender women or cis men with androgen decline or hypogonadism, sometimes used in reference to hormone therapy for trans folk, especially by the community themselves. And of course, it does make some sense in that we're replacing an endogenous set of hormones with an exogenous set of hormones. But this is all some of the language that you might come across. So I'll discuss some of the basics around it. Then I'll talk you through the process of actually prescribing gender-affirming hormone therapy and specifically the structure of that first patient encounter and the things that you need to do. And then we'll dive a little bit deeper into what exactly those baseline assessments are. We'll talk a little bit about some of the options for feminizing hormone therapy, for masculinizing hormone therapy, the risks, the benefits, the side effects, the changes that one can expect in the timelines, and so on. We'll speak about the follow-up strategy for once we put our patients onto treatment, and then we'll touch briefly on hormone therapy in non-binary folk. So the basics of gender-affirming hormone therapy, why do we use it? What is it? Some of the important points that I need to get across at the outset is just to say that we are very well convinced with good scientific rationale that hormone therapy for trans folk is safe, it is effective, and in fact, it is essential. It's not cosmetic, as some people would erroneously think. And certainly even in South Africa, hormone therapy is listed on the EML, the essential medicines list, albeit at higher levels of care, but nonetheless regarded as an essential treatment. So gender-affirming hormone therapy is an intervention that we know is very, very effective in improving outcomes for trans patients, and that it does so at a relatively low cost. And we know that it is a safe intervention. So this is something that should be carried out on an informed consent basis, and discussing the entire informed consent process and philosophy is a little bit beyond the scope of the discussion that I'm going to have with you today. But nonetheless, I think you'll have already touched on that in other sessions today. So the choice to go on to hormone therapy should ultimately rest with the patient. We shouldn't see it as our role as prescribers or providers to determine who gets access to hormone therapy, who is trans enough. This is very outdated thinking, and it does more harm than good. And we'll talk about that a little bit as we continue our discussion. And then just to understand at the outset that coexisting conditions, whether it's dyslipidemia or diabetes or whatever else it is, really we should, mental health conditions, HIV in particular, we should endeavor to see coexisting conditions not as contraindications to hormone therapy, but rather as entities that will require management alongside the provision of hormone therapy. So not something that we have to fully resolve or manage or cure before we start hormone therapy. We shouldn't, what I'm saying is we shouldn't delay the onset of hormone therapy or the initiation using other medical or mental health conditions as an excuse for that. So let's do a little bit of myth busting. And these are, and I hope that all of this is obvious to you, but if it's not, that's okay. There's a lot of people who still harbor some of these misconceptions, and that's why I'm going to address them for you today. So hormone therapy, or the provision of gender-affirming hormone therapy, is not necessary to validate trans experience. So whether a trans person is on hormones, isn't on hormones, has never been on hormones, doesn't want hormones, does want hormones, it doesn't affect the validity of their identity. So this, again, technically beyond the scope of today's discussion, but we should endeavor not to medicalize or pathologize trans experience, not to see it as only being valid when someone is on hormone therapy. It's not a benchmark for that. As we'll discuss, there are some patients who do want hormone therapy, many patients. There are some patients who don't want hormone therapy. There are some patients who, for whatever reason, might not be able to be on hormone therapy, and all of those experiences are still valid. Following on from that, I want to point out that there isn't a strict roadmap that medical gender affirmation follows. So for a long time, we imposed sets of standards or ideas or expectations on our trans patients and the medical management of our trans patients. And we required people to adhere to these, almost to tick off the boxes, even if it wasn't true to who they are. And it really resulted in because patients are smart and they figured it out, it really resulted in patients feeling like they were unable to be open and honest and forthcoming with their providers about their actual lived experience. So it ended up creating a barrier to care, and it didn't really serve anyone. So we shouldn't think that any two trans experiences are alike, or that any two patients will have the same expectations of their gender-affirming care. Certainly there might be patterns and there might be certain expectations or ideas that are more common than others, but we should keep open minds and open hearts in managing our patients and realize that everyone has different expectations, different needs, different requirements, different goals, and all of those are valid. Gender-affirming hormone therapy is immensely effective at treating and reducing dysphoria, but on the other hand, dysphoria need not be a prerequisite for gender-affirming hormone therapy. So while a lot of patients do experience gender dysphoria, we are trying to move away from that kind of language when we discuss trans identity and gender incongruence, we've evolved some of the language. So we no longer talk about a gender identity disorder, and we're trying also not to talk about gender dysphoria because it necessitates that a person experience a degree of distress, suffering, or trauma as a result of their gender identity. And we really want to move away from that while still recognizing that some people experience dysphoria, but dysphoria not being a prerequisite for accessing gender-affirming hormone therapy. Similarly, while a lot of trans patients might have coexisting mental health considerations, and while a lot of them might benefit from therapy or support or counseling or interaction with a psychologist, psychotherapy is not an absolute requirement for gender-affirming hormone therapy. So this idea that people have to go through X number of arbitrary months of psychotherapy before getting access to hormone therapy is an outdated one, and this is no longer recommended at all. Following on from that, what was called RLE, or real life experience, basically the expectation that a patient should live and work and socialize in their experienced gender role for a set period of time. Often it was quoted as 2 years before getting access to hormone therapy is not something that we do anymore. And that's because it's exceedingly problematic. We understand that gender is much more simple than just masculine and feminine, and the expectation that someone succeed in a gender role, in a particular gender role, is really just an antiquated and an outdated notion. Gives rise to all sorts of questions around, well, what defines success? Is success in the role of a woman being harassed or catcalled or whatever else? How do you define being successful in a non-binary gender role? Aren't gender roles all systems that have the potential to be oppressive and unjust in any event? So as you can see, there's all kinds of complications around this expectation. Plus, it's utterly inhumane to expect someone to navigate the world for a fixed period of time while denying them the kind of support that medical intervention or gender-affirming hormone therapy provides. So real life experience, out the window. That's what you need to know here. So who should have access to gender-affirming hormone therapy? Well, the short answer is anyone who wants it. And you can see here the indications for gender-affirming hormone therapy that I've taken out of these South African guidelines. So the indication number 1 is the patient or the client or the individual should have a desire to use gender-affirming hormone therapy. We're not putting anyone on hormones against their will. The second thing is that there should be a persistent incongruence between assigned and experienced gender. So we're shifting all of the language away from the binary here and really focusing on incongruence rather than dysphoria. And then thirdly, the individual should have the capacity to make an informed decision and give consent to treatment. And I'd encourage you to take a look at the definitions around informed consent and capacity when it comes to making this assessment. But the long and the short of it is that in the case of an adult, effectively, the only real scenarios in which someone would fail this criteria, would not meet these criteria, is if they're under the influence of alcohol or substances, or they are actively psychotic, or in some cases of severe intellectual impairment, of course. But in general, an adult will be able to understand the information and give consent to undergoing treatment. So now we know when to use gender-affirming hormone therapy. The next question that we have to answer is, how do you do it? And the takeaway points here, to come back to what I said to you a little earlier on today, it's easier than you think, and you already have the skills to do it. So I'm not going to teach you anything new today. I'm going to tell you about doing physical examinations or taking a history or ordering laboratory investigations that you already do for other patients. I'm going to teach you how to prescribe medication that you probably already used in some or other form somewhere else. So this is not beyond your grasp. And this really comes back to what I said about I want this to be empowering. I want to show you that it isn't that difficult and that you are going to be able to do it. So what is the process when we interact with a trans patient for the first time? How do we manage that? What are the things that we need to do? And this is what we're going to talk about here. So just to give you a brief bird's eye view of all of it, I'm going to talk about that baseline assessment, that first interaction that you have, and taking the medical history, doing the clinical examination, and ordering the relevant baseline investigations. From there, we're going to go on to having a discussion and going through this informed consent process with our patients. We're going to talk about the risks and the benefits of hormone therapy, the reversibility of the interventions, the changes that someone can expect to see, and the timelines. Often we have to do a little bit of expectation management, not always, but sometimes, bearing in mind that a lot of our patients have done their research on this, whether on the internet or from their peer groups, but that some of the information that they get access to is not always entirely accurate. So sometimes we have to explore these ideas and manage the expectations of the patient when they're unrealistic. For example, I have had patients sit in front of me who have thought that going on to feminizing hormone therapy or estrogen is going to affect changes to their vocal cords. And that's not a realistic expectation to have. So we have to discuss that with patients up front. We are going to have to talk about reproductive options. We need to give our patients an opportunity to ask us questions and have them answered. And then we have to agree together with our patients on a mode of administration for hormone therapy. And then it's the actual initiation, the prescription of the medications, and arranging for follow-up. So we've broken it down for you quite nicely in the guidelines document, which I'm sure by now you all have an idea of where to find, but just a little flowchart or algorithm here to help you through these steps, the discussion, the assessment, the initiation of treatment, and the monitoring. So let's zoom in a little bit on the baseline assessment for patients. And as I've said to you a moment ago, the first thing that we need to do is we need to take a medical history. You will have done this if you're a clinician countless times before. It's not any different when you do it for a trans patient who wants to go on hormone therapy or who's already on hormone therapy. We do want to put a particular focus or emphasis on screening in the history for liver disease, kidney disease, cardiovascular illness, any kind of venous thromboembolic disease or clotting, the presence of malignancies or neoplasms, dyslipidemias, diabetes, or any other metabolic or endocrine disorders. So we want to ask specifically around these things, but we want to take a general medical history the same way that we would for just about any other patient who sits in front of us. We also want to look at a family history, and again, looking at a family history of hypertension, cardiovascular disease. We want to look at specifically any malignancies, any thromboembolic events, any diabetes or metabolic or endocrine disturbances. Then we want to be sure to collect a surgical history from our patient, any procedures that they've had done, not just gender-affirming procedures. It does help to specify this because often when you ask your trans patient about surgery, that discussion can easily be misinterpreted. So I find it helpful to say, have you had any surgical procedures done in your lifetime for any reason whatsoever? And then, of course, we need to find out if our patients are allergic to anything, predominantly medications here, but foodstuffs and additives might also be relevant. After the history is done, we want to do a physical examination. And what we're looking for here are the stigmata of chronic illness. You may know the acronyms JACOLD or couch cold, whatever was used in your particular institution of higher learning. we want to do a brief systems examination. So we want to check vital signs. We want to do a brief respiratory exam, cardiovascular exam, abdominal exam, etc. The same kind of thing that you do in your first interaction with just about any patient for any reason. And a special note here to say that it's unnecessary to examine your patient's breasts or genitalia unless there's a particular indication to do so. And of course, if that is the case, then to do so with the requisite sensitivity and consent from your patient. So often it's an expectation of patients that they'll have to have these kind of intimate examinations done. It can be a huge barrier to care, to accessing care for patients. And it helps, I often just reassure my patients up front that I'm not going to have to do any intimate examinations unless there's a particular reason to do so. Having completed the physical examination, we can then move on to discussing reproductive options with our patients. So important to understand that for the majority of patients, going on to hormone therapy is going to, at some or other point, render them infertile because estrogen will have an effect on spermatogenesis, and because testosterone used in the kind of therapeutic dosages that we use often will result in anovulation or the absence of ovulation. So important to discuss reproductive options with our patients. Having said which, I always take care to remind my patients that hormone therapy alone should not be relied upon as a means of contraception. And if patients are engaging in the kind of sexual behavior that could lead to them becoming pregnant or impregnating someone else, and they don't want to do that, then they should use alternative forms of contraception. But we always want to have this reproductive discussion with patients, ideally before they start on hormone therapy, because in some instances, the effect on fertility may be irreversible. We don't always know when it kicks in. And if we try and take patients off of their hormone therapy to regain their reproductive potential, this can be a costly and time-consuming exercise. And furthermore, many of our patients will never have been pregnant or impregnated anyone else. So we could be chasing a baseline of fertility that we don't even know for certain was there to start with. So it always helps if we can establish beforehand that if a patient's going to want to preserve eggs or sperm, that we do that before initiating hormone therapy. Having said which, many of my patients have no desire to bank genetic material, either because they're not interested in procreating or because they've already decided that they are more than happy to adopt kids, or simply because these procedures can be quite costly. So for some patients, they will elect not to preserve genetic material, and we should allow them to make that decision without judgment, while of course offering them whatever kind of support we can. So that leaves us with the laboratory investigations to discuss. And I'm going to show you a quick table that I've lifted from the South African guidelines to show you exactly what investigations are needed. We suggest a different set of investigations. So if you are able to do them, a full set of investigations would include a full blood count, a electrolytes, urea and creatinine, an LFT panel, a fasting glucose, and a fasting lipogram. Whereas if you're in a resource constrained setting, then we'll pare that down, and instead of a full blood count, just do a hemoglobin or hematocrit. Instead of the full UENC, just do the creatinine. Instead of the full LFT panel, an ALT. Instead of the formal fasting glucose, just a finger prick or random glucose. And instead of the full lipogram, just a total cholesterol. Also recommended, depending on whether it's clinically appropriate, which we'll get from the history that you take with your patient, HIV, hepatitis B, and syphilis. For patients who will be starting on masculinizing therapy, it is quite important to ascertain that those patients are not pregnant before they start. So in some instances, you will need to do a pregnancy test. In other instances, it won't be necessary, and you will let Your discussion with your patients guide that. So I just say to my patients, is there any possibility that you might be pregnant? And do we need to test you? And I let that guide me. So we will focus now on feminizing gender-affirming hormone therapy. The goals of feminizing GAHT are firstly to induce feminization, and then secondly to suppress production and the effects of the androgens. So we know that testosterone has some potent effects on skin texture, body odor, body hair growth, scalp hair, etc. We want to eliminate as many of these effects as possible, while also inducing the development of secondary sexual characteristics, such as the development of breast tissue, for example. In order to do this, there are a couple of general principles that we adhere to. So we prefer to use bioidentical hormones in favor of synthetic hormones or equine hormones. So I will prefer to use an estradiol or a 17-beta estradiol in favor of an ethanyl estradiol or a conjugated equine estrogen. And the reason for this is that the bioidentical hormones tend to be significantly safer than the synthetic hormones in terms of the risk profile, which we'll go on to discuss. The second principle here is that we prefer, whenever possible, to use parenteral estradiol or parenteral feminizing hormone therapy instead of oral hormone therapy. And the reason for that is that the oral treatment is subjected to first-pass metabolism. So as it passes through the digestive tract, the first place it goes is the portal circulation and the liver. A significant portion of the estradiol will be metabolized into estrone. This firstly reduces the bioavailable fraction of estradiol and limits feminization. And then secondly, it also increases the thrombotic risk, which is associated with the estrone level rather than the estradiol level. So these are our basic principles: bioidentical above synthetic and parenteral in favor of oral, where it is possible. So that means that we would prefer to put a patient on the injection or the skin patch rather than on tablets. As part of feminizing gender-affirming hormone therapy, we might prescribe anti-androgens or testosterone blockers, as they're commonly known, if it's necessary, and we might prescribe progesterone. The jury is out when it comes to progesterone. We don't really have solid scientific evidence to say whether it helps or hinders. There are some commonly held beliefs, such as that we don't want to start it too early. Generally, one would only start it once a patient has achieved Tanner stage 2 of breast development. And we also know that if we are going to use progesterone, we should only consider using a micronized bioidentical progesterone. We should stay away from all of the synthetic progestogens. There's no place for medroxyprogesterone acetate or hydroxyprogesterone when we treat trans women. If we're going to use progesterone, it must be bioidentical. It must be the micronized progesterone. That would be under the brand name Utrogestin. It's also available compounded, and we know that it has superior bioavailability and a preferable side effect profile if it's administered as a suppository or as a pessary where it's appropriate, rather than as oral treatment. So we don't know if progesterone helps or hinders. When I have patients asking me about this, I will counsel them about progesterone, saying it may cause your mood to worsen, or it may cause your mood to improve. It may cause your libido and sex drive to worsen, or it may cause them to improve. And again, we don't necessarily know which of those outcomes would be more desirable for a patient. So make sure that they keep track of mood, libido, weight, metabolism, and so on when they go onto progesterone, so that if they have an adverse effect, we can at least take them off of it. As for the arguments around anti-androgens, certainly if it's possible to get away with using fewer agents, one should endeavor to do so, as it generally means less cost and fewer side effects for your patients. So when we use the parenteral estrogen, the patches or the injection, most often we'd be able to get away without the anti-androgens. And I'd say this is the case for me with somewhere around 98% of my patients who go on feminizing HRT, if they are treatment naive, when I put them on to parenteral estrogen, there's about a 98% chance that we'll be able to do without the anti-androgens, still achieve testosterone suppression, and have great clinical results. So here's a breakdown of some of the different agents that we can use for feminizing hormone therapy. I'm talking here about, so I'm not going to read through the entire table because once again, this is lifted directly from the guidelines where you'll be able to find it. But in short, our two preferred methods, the patch and the injection. Most commonly, we will use estradiol valerate as the injection. There are certain other estradiol esters that are available in other countries, but not really in South Africa. We prefer these methods because they're safe and effective. In particular, the estradiol valerate tends to be the most cost-effective option, while the patches, being safe and effective, can cost a little bit more. With both of them, we are usually unlikely to need anti-androgens in addition. And with both of them, we look at a very low risk of venous thromboembolism, the most significant potential side effect with estrogen treatment. We are always going to be cautious of some of the adverse effects that we can get from estrogen, notably migraines, nausea, mood changes, and of course changes to libido and sexual response cycle. Historically, people have said that it suppresses libido, but I find it's much more accurate to say changes the way that the sexual response cycle works. And of course, it's listed here as a side effect, but in a lot of ways, this is an expected and sometimes desirable effect of feminizing hormone therapy. The next option that we detail for you is 17-beta estradiol. This is sold as Estrofem, not as safe as the parenteral treatment, but certainly superior to, for example, conjugated equine estrogen or Premarin, or of course, ethinyl estradiol, which is found in the combined oral contraceptive pills. So if patients are self-medicating, often they'll be doing it with the contraceptives. This is often inappropriate because they contain a mixture of both a synthetic progestogen, which I've already told you not to use, and an ethinyl estradiol, which isn't really suitable for gender-affirming hormone therapy for the reasons that we've discussed. So there's the table for your reference. You'll be able to find it in the guidelines. Then we go on to talk about the anti-androgens. Predominantly three different molecules available: spironolactone, sapropterin acetate, currently in short supply in South Africa, so just worth bearing that in mind, and bicalutamide. Sometimes there might be a reason to put patients on GnRH antagonists as a hormonal androgen blocker, but the discussion thereof is once again a little bit beyond the scope of this discussion. So what I want to draw your attention to is just that a lot of patients do experience side effects from the anti-androgens. It's worth bearing that in mind. A lot of patients who've been on them for a long time will complain of effects on mood, anxiety, brain fog, perhaps memory loss. And this often because these molecules are capable of crossing the blood-brain barrier. And in addition to inhibiting the synthesis of sex hormones, they can also interfere with the neurosteroids. So a lot of reasons to try and avoid them. Obviously, in some instances, they are necessary. And then, of course, the other thing that we haven't detailed here, but which is sometimes has a corner case application, are the 5-alpha reductase inhibitors that inhibit the conversion of testosterone to DHT. But these are the kind of assessments that will be done on a case-by-case basis and don't really comprise the core body of knowledge that you'll need in order to prescribe hormone therapy for your trans patients. So here are the effects of feminizing hormone therapy. We've given here some of the common time periods associated with these changes, but please bear in mind, as I tell to all of my patients, that your mileage may vary, and most important is time and genetics, the two factors that are not under our direct control. So once we optimize your hormone therapy, sometimes patients are a little frustrated at how fast or slow they're progressing, and always just important to remind them that every individual physical body is different, reacts to hormones in a different way, and quite important not to compare progress to their friends or their peer group because everyone's physiology is distinct. So these are a general guideline, and we've given you the time that we start to see these changes and the time that it takes to reach maximum effect, as well as whether they're reversible. Important to note here, what we can expect to see: body fat redistribution, a decrease in muscle mass, softening of the skin, change in sexual desire, please note the language, decreased frequency of spontaneous erections, breast growth, decreased sperm production, possibly irreversible, and breast growth. Irreversible in that if someone discontinues their feminizing hormone therapy, breasts will get smaller because body fat will move away, but the actual structural components of the breast tissue, the development thereof is irreversible. And then, of course, please note voice change, time from initiation to onset, none, because as we said before, we need to manage expectations. There are some things that estrogen cannot do, cannot change someone's voice, it cannot alter their bone structure, for example. And that's just about it on feminizing hormone therapy. So from here, we'll move on to discussing masculinizing gender-affirming hormone therapy, where the goal is really to promote virilization. You'll notice that I don't say anything here about suppressing estrogen production, because this generally happens just kind of par for the course. So we almost never have to use specific agents to antagonize or block the effects of estrogen, just because testosterone is quite a potent molecule and it has such a significant effect that it essentially overrides and steamrolls the effects of estrogen. So important to know at the outset, we do not use any oral forms of testosterone for our trans patients. These are not appropriate for use because of the effect that they have on the liver. And then just another note to say here, so we're going to be discussing testosterone in its various forms, and that's the only medication that we need to use in a small subset of patients who will experience persistent cyclical bleeding despite being on testosterone, and for whom that's undesirable. There is sometimes a case to use other agents such as leuprolide, that's the GnRH antagonist that I spoke of earlier, medroxyprogesterone or Depo-Provera, such as the injection, or anastrozole, but these are few and far between. When we speak about masculinizing hormone therapy, the risks that we're looking at are predominantly metabolic, things like dyslipidemia and hypertension, and also just bearing in mind that testosterone will cause, it is expected, to cause an increase in hemoglobin and hematocrit, and there's a potential risk for polycythemia. So you'll remember when we discussed the investigations, these are some of the baseline things that we'll look at as a full blood count or an HB or an HCT so that we can keep an eye on this. How do we administer the testosterone? Predominantly as an injection or otherwise as a topical treatment. So the testosterone options are essentially all parenteral for reasons that I've already discussed. The effect of oral testosterone on the liver means that we can't use it in our trans patients. Most commonly, we'll use testosterone supinate. This was sold as depo-testosterone. It's the most affordable form of testosterone that's available, and it also allows us to have very precise control and titration of a person's dose. So depo-testosterone itself, unavailable globally since August of 2021, but there is a testosterone supinate that can be compounded at similar cost to the depo-testosterone. The other option that we have, testosterone undecanoate. This is libido. This is the long-acting testosterone ester where we don't titrate the dose, but we can titrate the dosing interval. So the dose is always fixed. It's 1,000 milligrams. It's 4 milliliters. That's it. The adjustment that we can make is how frequently we give it to our patients, which is generally every 10 to 12 weeks. On the other hand, with the testosterone supinate, because of its half-life, we should be using this as a weekly dose. So you'll see here we do discuss dosing options for patients who are dosing every 2 weeks. In my clinical experience, we would prefer to put patients on a weekly dose because they tend to feel the hormone slump. If you extend their dosing interval beyond a week, you'll find that the closer they get to dosing day, the more energy levels dip, the more irritable they become, the worse they feel. So given the half-life of testosterone supinate, makes most sense to do it as a weekly dose. But of course, resources or practicality might necessitate 2 weekly dosing. Again, the majority of my experience suggests that patients will generally do fine at a maintenance dose of 50 milligrams per week, but everyone is different. So you'll see here that we've given you some instructions for sampling the testosterone levels and measuring them to ensure that you're treating them adequately. And the goal there is to ensure that throughout the dosing cycle, patients will remain within the reference range. And I'll talk more about this later, but remember to use the appropriate reference range for the treatment that you're prescribing. So if a patient's on testosterone, we should use the male reference ranges. So we want to make sure that they spend the majority of that week in the reference range as much as possible, and various strategies to doing that. You can measure at peak, you can measure at trough, you can measure halfway between doses, but we want to keep them in the reference range. Then the last option that we discuss here, topical testosterone. This is the androgel, little sachets. It's an alcohol-based gel. Super great option for patients who are needle phobic, but a little bit cumbersome in that you have to apply it to a large proportion of skin, a large surface area, and it has to dry completely before a patient gets dressed, which can take about a half an hour. And also you've got to be aware that skin-to-skin contact can result in other people absorbing some of the testosterone, which might be undesirable. Here again, I list for you the expected changes on masculinizing HRT, the reversibility thereof, and the general timelines associated with it. So of note, the irreversible effects are the development of facial hair, male pattern baldness, if your patient has a predisposition to it, could be irreversible. The infertility or anovulation could be irreversible. Clitoral hypertrophy or bottom growth is considered to be irreversible, and the thickening of the vocal folds is irreversible. So there you have it. We've covered feminizing hormone therapy and masculinizing hormone therapy. You will have all of this information for easy reference within the South African guidelines for gender-affirming care. Now, we've spoken about the baseline laboratory investigations. When do you do the tests? Well, we do them at baseline. Then we'll want to do bloods again after 1 month. I'll tell you what tests to do in a minute. And then in the first year thereafter, we will do them 3 monthly. And once we're out of that first year, we'll do annual blood tests, but we'll review our patients clinically twice a year. Twice a year, I want to see my patients who are stable on hormone therapy, and I want to make sure everything's going okay with them, and I want to do a clinical examination for them. I remind you again here to use the reference ranges appropriate to the kind of treatment that your patient is on. So if it's a patient on feminizing hormone therapy, I should be using female reference ranges, not just for the hormone levels, but also for everything else that we look at, the UEC, the LFT, the you name it, full blood count, etc. We should be using the appropriate reference ranges when we do that. So here's the table detailing the laboratory investigations that we'll want to do, and the situations in which we do them, as well as the timing. Again, not difficult, not anything that you have to remember. Easy access to this information. Should you need it, you can find these handy references in the guidelines that we've produced. So what I hope you'll have been able to take from this is just that the process of putting patients on to hormone therapy and then managing them is really something that is well within your grasp. And one of the things that I'll touch on just before we end off is what we do with non-binary patients. But we've been through the general use scenarios for feminizing and masculinizing hormone therapy now. And you'll understand that taking the history, doing the clinical examination, ordering the investigations, even prescribing the medication, because it's the same kind of medications that we've been using to treat menopause or impotence, et cetera, for a long time. These are all well within your grasp. What do we do when it comes to non-binary patients? The short answer is that your guess is as good as mine. The longer answer is just that we have to have quite a deep and frank conversation with our patients in order to find out what their expectations are, in order to make sure that we manage those expectations if they're not realistic, that we have a good discussion about the risks, the benefits, the reversibility of changes, so that patients understand that there's a variety of effects that hormones can cause, and that unfortunately it's not possible to pick and choose what you get or when you get it. But also to make sure that you set up the kind of relationship and dynamic with your patient that is collaborative, where you work together towards their goals. So when I see a non-binary patient, my primary concern is for patient safety. And with patient safety as the guiding principle, I want to make sure that I let my patient's treatment be as self-directed as possible. So I'll always explain to a patient, you know, the human body requires a predominance of either estrogen or testosterone in order to function. This is necessary for mood, for libido, for cardiovascular health, for bone health, and so on. So I can't fully deprive you of one hormone without replacing it with another one. Having said all of which, there's a lot of patients who are wanting to start off on low doses or microdose, or who want to go slow, or who want to go on hormone therapy for a fixed period of time. Maybe it's a patient who really wants their voice to drop or wants to develop facial hair. These are irreversible effects. So sometimes they'll want to use hormone therapy for a period of time and then go off it. So we discuss all of that up front. And I remind my patients that they don't have to commit to and set in stone all of the expectations or goals or trajectory when we get started, but that it's helpful for me to have a general idea or an overview of what they're looking for so that we can work together in order to try and achieve it. We will again do the same kind of history taking, physical exam, laboratory investigations with that particular focus on safety. And very important here is just to remember that it's not our role to judge patients or to project our expectations of, well, if you're going on testosterone, then you must want X, Y, Z, etc. This is the standard recipe. To not put those expectations or project those ideas onto our patients, but rather to listen and to understand, to manage expectations where it's necessary, and to try and develop and foster that collaborative approach with our patients, which will not only result in greater patient adherence to treatment, and I'm not just talking about the medication, but I'm also talking about follow-ups and blood tests and so on, but greater patient satisfaction and, of course, better outcomes at the end of it. And this is ultimately what I say to my patients, whoever they are, binary, non-binary, etc. When I see them for their follow-ups, you know, often they have done their blood test, they want to discuss the results and whatever else. And I'm always quick to remind them that while the laboratory investigations are important, I'm much more concerned with your experience and your quality of life. Did hormones make life better on them than it was before them? And that's really the whole point, to go through all of this rigmarole and process and whatever else. Ultimately, it needs to improve a patient's well-being and quality of life. And that's the reason that we should do it. So, with all of that said and done, I hope that I've given you enough of an overview to understand that hormone therapy is safe, effective, often it's cost effective, that it has a significant role in improving outcomes for patients, that it's not a cosmetic endeavor, but it's an essential endeavor, and that it is well within your purview, your skill, and your expertise to be able to do the baseline assessments, the interview with the patient, the informed consent, and of course to prescribe and monitor a patient's treatment when they are accessing gender-affirming hormone therapy. I hope that it has become less intimidating and less scary, and that you perhaps gained some insight into a few of the principles and nuances behind it, and that instead of fixating on remembering the names of the drugs and the doses and the quantities and the frequencies of prescribing, that rather you'll focus on the how and the why of prescribing hormone therapy, and be kind to yourself, allow yourself to look up the rest of the information, which serves the added benefit of making sure that you're getting the latest, most up-to-date information, because of course that is subject to change. But understanding the rationale and the approach to facilitating access to gender-affirming hormone therapy, I'm certain is not going to change. And it's much more difficult to look that up in a table. So I hope that we've been able to do that with our discussion today. And I hope that you've gained from this. So enjoy the rest of the symposium, and happy prescribing to you.